Okay, so I'm happy to introduce Haley Schuman, who is a clinician scientist in training. So I think she mentioned in her introduction, as soon as she finished her master's with me, she started med school. So she's halfway through her first year, and I can't believe she's even still standing and able to join us. So she has a background in biological sciences, psychology, and medical sciences. She leads key research and knowledge translation projects for CAN-PACT, focusing on the clinical implementation, safety, and ethics of psychedelic-assisted therapies in oncology and palliative care. Haley's interdisciplinary experience spans direct patient care, advocacy, and qualitative research. She's committed to advancing integrative oncology and promoting collaborative approaches between patients, policymakers, and the research community. Okay, we good to go?
Yeah.
Awesome. So welcome, Haley.
So do you want to have the mic?
We're going to give you a lapel mic. I think that's the way we're going to do it. So, put it on whichever side you think you're going to be leaning towards. Just make sure it's turned on. So, 3, each. That's it.
Hello. Hi everyone. So yeah, again, my name is Haley. I've been privileged to be able to work with Linda in my undergrad, my master's, and now I just can't say goodbye, and I probably never will. I just wanted to share. I was thinking about Dr. Shore, who was on my committee for my master's, his brilliant talk yesterday. And just talking about fungi and mycelium and the underground network and how at different layers of the mycelium they have different roles. And I took a biology of fungi course in undergrad that was very transformative for me. And I was just blown away by just how remarkable the fungi is, and even the evolution of fungi, of how from aquatic life and how we're able to come on land and how fungi participate in that in a big way. And I told my now husband, when I was 19 or something after my course ended, I looked at him and I said, if fungi wanted to, they could take over the world, but they're just not going to. Yeah. So I was thinking, yeah, they're very wise. Okay, so yeah, I'm gonna take you through as cohesively and concisely as I can my master's thesis, which goes through 4 different papers, projects that all kind of interconnect.
And Haley, you can go till almost 10:30 if you want.
Okay.
Okay, so don't rush.
Okay. And something that I like to do, so for every paper that we are currently in the process of publishing and in my thesis, I like to embed a quote. And I also there's an alignment there with also setting an intention for a psychedelic experience. And so as I go through this and tell you guys a bit of a story to the best of my ability, I want to take this quote from a book that was very pivotal for me, and I read it during my master's. It was by Dostoevsky, The Brothers Karamazov, and this is by a character named Eldon Zuzissima, where he says, "Each blade of grass, each little bug, and golden bee knows its way amazingly. Being without reason, they witness the divine mystery. They ceaselessly enact it." So Elder Zuzissima reminds us that meaning is not something we create, but something we perceive when our vision changes. In this passage, for me, Zuzissima describes a world alive with purpose, where even the smallest living thing participates in the mystery of being. He sees no separation between darkness and light, suffering and beauty, and to him the world is both fallen and redeemed, tragic and luminous, depending on how one sees it. And in many ways, for me, this idea mirrors the central tensions explored in psychedelic-assisted therapy for people living with cancer. These experiences do not necessarily remove the pain or fear that they face, but they can shift how individuals relate to them, revealing moments of clarity, connection, or even sacredness among profound uncertainty. So our work should strive to sit within that intersection between suffering and meaning, science and spirituality, asking how these experiences might be understood, integrated, and ethically translated into the realities of cancer care. And I'm a bit of a philosophy gal, so forgive me for needing to talk about that. So what is the work that we did in my master's? So we know that there's hype. We know that there's this hype level since particularly the 2010s. There's interest, there's enthusiasm, but that doesn't necessarily translate into endorsement. And we really need to tease out with key stakeholders that actually will shape the future of psychedelics in cancer care in broader context, and ask them, what do you really think about it? And furthermore, tease out substance-specific understandings and preferences. Because currently, and it's being, commercialized, operationalized, marketed as the umbrella term of psychedelics, but each agent underneath that and whether or not certain agents should be fit under that need to be discussed more. So what I'm going to walk you through today is how we attempted to do this. And each of these projects throughout included collaborations with patient partners using the patient-oriented research framework with CIHR. I had about 6 patient partners, some at different stages, but one that was very integral to me I met in 2022 at a conference. It's also where I met Dr. Shore. And that was Purdy, who's here today, and I'm very grateful that she's here. And I got to hear a bit about her story, and I came up to her, and I think I talked to Lynn, and I said I need her on my team. So that was super pivotal for how we constructed our design, our study, and understanding our findings. So we started with a systematic review, and then I'm going to walk you through part 2, which is our national survey, where we spoke to different stakeholders across Canada. And that then informed our qualitative analysis, where we did in-depth interviews with both patients and healthcare providers. And so this was recently, our systematic review and meta-analysis was just published in Current Oncology over the summer. So to our knowledge, this is the first oncology-specific synthesis. And for various reasons, partly because there's just not enough studies to warrant a systematic review with just the oncology population previously. So they would group cancer and other life-threatening illnesses together. So again, this is the first one where we looked at, for adults with cancer, how were different psychedelic agents effective in treating depression, anxiety, and existential distress. And we were able to use 3 psilocybin trials and 4 ketamine trials that were randomized controlled through a meta-analysis, and then narratively, to kind of contextualize our findings, we also included an MDMA and LSD, 2 LSD trials, as well as an open label and ketamine and psilocybin and 3 psilocybin trials. So 15 in total after reviewing through our whole lab participated and helped me with this, over 1,000 studies, and then we brought it down to those 15. And as well, to further contextualize the findings, we looked at how there was a divergence in therapeutic supports and delivery settings, and explored possible implications from that. And I think it's worth mentioning that we made the deliberate decision to include ketamine for very good reasons, and there's a good debate on whether or not it should be included and classified as a psychedelic. However, that being said, it is frequently marketed and operationalized alongside psychedelic therapies, both research in clinical settings and also in the private sector, especially as we're seeing in Alberta. And its growing off-label use in oncology and psychiatric settings made its inclusion important for that contextual completeness. And also, I wanted to include it so that we could have more conversations around the divergences that we can see in the literature. So, very quickly, it's, a little boring, but for ketamine, so it was 4 randomized controlled trials. All of the ketamine was administered intravenously. 2 were post-operative, and then the other one was for suicidality, and then for depression for women with breast cancer. And we see that, so kind of what characterizes a rapid, strong effect is the head G. A strong effect would be a 0.8. Strong impact on treating, for this it was depression. And the measures were for kind of short term, from 1 to 3 days. And similarly for psilocybin, and we used the 3 trials that were discussed yesterday, and which with a significantly kind of smaller sample size, we similarly saw a rapid reduction in depression with HG of 3.13. However, psilocybin did not reach statistical significance, and you can kind of see that by it had a much greater confidence intervals, and that's likely due to the fact that the sample size was just so small that it wasn't able to reach a significant effect. And what that means is that this doesn't mean that it's not effective. It's just because of the smaller sample sizes in the early phase trials, we expect to see the heterogeneity. And then, so across the 15 studies, we identified a clear divergence in how these agents are conceptualized and delivered, at least in these trials. So psilocybin and another serotonergic psychedelic, LSD, and then an atypical psychedelic, MDMA, also known as ecstasy. So those are what we saw as they were delivered in very structured psychotherapeutic models that emphasize setting, and integration, and a process aimed at transformative meaning-making and relief from existential distress. In contrast, we see that ketamine is delivered in a very medical infusion context with no psychological framework, but they saw that it offered rapid relief in short-term measurements. And as I was kind of thinking about this slide yesterday, I've had an opportunity to work in some private settings with ketamine clinics, and so what I'm seeing in the literature in the cancer context is that it's a very biomedical delivery, but in the private sector, they're using ketamine in this context often. So I'd love to have a debate about all of that. So now this brings us to part 2. So this is our national survey where we looked at what the heck are people thinking about psychedelics, speaking to those key people that will play a pivotal role at different levels in informing the integration and implementation of psychedelics into oncology context and also broadly. So we were able to recruit just over 500 people living with cancer. We had 187 healthcare providers, and policymakers are very difficult to find, about 36. So totally we had 742 participants, and we're able to recruit a good representation across Canada, across different ages, adults, and religious also identification. We had a good representation of people that had no identification, were Christian, Catholic, Muslim, and Buddhist, and other representations there. So we did our best to do that, and our sample was about 60% white. So, of course, we always need to strive to improve that. And we did a 95-item questionnaire that was tailored to each stakeholder, while also having crossover between the different groups, so we could do this between group analysis that I'm going to walk you through a bit right away. So firstly, we used a validated survey that was developed in 2022 by some European researchers, the Attitudes Towards Psychedelics survey, and they validated the general population also with psychiatrists. And to our knowledge, this is the first time that it's being used in North America. And yeah, I'll walk you through it a bit. So first looking at the kind of lower right quadrant, this is looking at just overall attitudes. A higher score in the box plot means that they're more favorable towards psychedelics. And the general trend across the subscales and with their total attitude is that patients showed, were most favorable, and then there was no significant difference, at least in this one, between healthcare providers and policymakers. They're just between the patients. And then what was interesting is that there was significant differences from patients to the healthcare providers and policymakers, looking at the different subscales for the risk concerns. So healthcare providers and policymakers did show more conservative views about risk, the legal use, and also just overall openness. But there was no significant difference between the perceived effects. So they're meaning that there's that kind of duality where they see that it's effective, but then there's these contextual factors that are influencing their overall attitudes around, well, we don't understand the risks. Of course, legality is a crucial thing, and therefore, I don't know if I'm as open. And what we wanted to understand was what were kind of the key predictors of what led the participants to be more positive towards psychedelics. And this is something we're going to dive into more with in-group analysis and subsequent papers that I'll talk a little bit about at the end. But for patients, prior psychedelic use was a strong predictor to be more favorable towards psychedelics, which we've also seen in previous literature. And across the groups, we see that reporting greater knowledge was a negative predictor. So The more that they felt that they knew, that they reported, that was an indicator for them being less favorable towards psychedelics. And then, of course, being a healthcare provider, and then even more so being a policymaker, was a greater negative predictor relative to patients on being, being positive towards psychedelics. And this accounted for about 30% of their attitudes through our regression model. And now, again, teasing out a bit about the different psychedelic agents. And again, we're focusing on ketamine, LSD, MDMA, and psilocybin. So just to take you bottom up from just the color scheme. So we have, red and orange mean, starting with the left panel, very effective to somewhat effective. Gray means I'm neutral about it. And yellow is where they would indicate it's somewhat ineffective or not effective at all. And we see that across the board, about 79% across stakeholders believe that psilocybin is the most effective. They believe is the most effective agent, whereas with ketamine across the groups it was only at 49%. And actually, for healthcare providers and policymakers, they had a greater belief in its effectiveness, or at least weren't as neutral as we saw patients. And in contrast to that, there was a bit of an inversion. When we go to the right panel, so again, red and orange indicating they're very concerned to somewhat concerned, and then gray, neutral, and then yellow, I'm not worried about it. We see that, so there's kind of increasing concern starting with patients, healthcare providers, and then policymakers had the greatest concern. So again, showing that paradox where, okay, we look at policymakers, they're super concerned about psilocybin, but then they're also think it's super effective. So again, this is, our hope is that this information can also lead to what I hope the subcommittee can work on through education. That is a major gap right now. And then asking participants about their barriers, we find that it's very specific to their lived experience and what they have to deal with. So for patients, the chief concern was financial resources. And this was further contextualized when I spoke to them in the qualitative interviews, where they, their understanding is like, how am I going to afford this? And also the lack of healthcare provider support, and not really, again, I'm contextualizing this through the qualitative interviews, not feeling, comfortable even asking their healthcare providers about it. And then safety concerns and legal challenges. And then for healthcare providers, the chief concerns was training and education. Where would I go? Who do I even feel comfortable asking? And then for policymakers, they were, where's the research? So that's, and I guess their concern was around social stigma, realities, and legal issues. So that was some interesting stuff there, and to kind of just finish it off, we had a lot of interesting information in this paper with 7 different objectives, but I just kind of picked and chose some things that I thought would be interesting to you all. But ultimately, out of our sample, we see that 93% of patients desire access. And similarly for healthcare providers and policymakers, over 60% are interested in wanting training and education. So that's important. And now, based on those findings, and working with patient partners, we wanted to get further information of, based on that, how can we tease out and further understand where these perceptions and understandings are coming from. And so this was for our qualitative analysis speaking to patients that was published in September in Integrative Cancer Therapies. So we recruited all our participants through our national survey, and we did our best to be intentional about getting diverse cancer stages, so we kind of equal representation from stage 1 to stage 4, and also types, and ensuring that we had half that had psychedelic experiences and that half that did not. And here, and for our analysis, we used reflexive thematic analysis, which I'm happy to talk about afterwards, and to kind of make a skeleton of our codes, because we have so much rich text and quite lengthy interviews. we used a theory of planned behavior to help kind of organize our codes and kind of work out from there. And here's just a quote from one participant that did have a psychedelic experience, and they say that it was quite life-changing for me, and in how I viewed existential distress and how I look at death down the road. And kind of going back to the title of our paper around facing death, now that's a serious thing to confront. Underpin of paper and this speaking to these participants was that conversation, and perhaps gaps that they felt they were missing in their care. So I've done this presentation a few times, and I often I do a high-level overview of major themes that emerge from our qualitative analysis. But then I was thinking I was never happy with it, and I realized the reason for that is because I need to just really tell you what the patient said and the patient voices. So I'll quickly kind of go through this and then just highlight the next two slides. What did the patients really say, so you know what I'm talking about. So how we kind of organized it was, starting with kind of attitudes. So they balanced openness. So all of them were, I could be open to this. Some, I have no idea, but I would do anything. But also with caution, and that was very substance specific. That being said, psilocybin seemed to be the most accepted among the participants, and what they associated that with was the idea that it was something natural. They didn't want to take any other, pills or chemicals, and they just wanted something natural, and so that's what they felt an affinity towards. And secondly, looking at the top one around unclear access pathways, continually what was expressed was, how the heck, who do I talk to, where do I find it? So that was a conversation, and then around healthcare providers and the comfort that they feel or did not feel speaking to them about this. And I'll talk about, and then also the gaps in psychosocial care, particularly around as we talked about yesterday, Deanne mentioned, is, regardless of the stage of cancer you're at, and Linda mentioned, the idea of death and facing your mortality is something that there's a conflict with that you have to explore. And relational influences, so your support systems, are they for it, are they judgmental? That plays into their openness towards it. So of course we're not going to go through all of this, but I just wanted to read a few quotes to highlight how each substance had very different kind of attitudes and beliefs, starting with, ketamine. My understanding is it's a horse tranquilizer. Okay. And psilocybin, again, showing openness, having a regulated guided psilocybin session, I would still do it in a heartbeat. That one has more natural source. That one that has more natural sources do feel like, to me, they feel safe. And LSD, I think LSD probably makes me feel the least comfortable. So, understanding that more and where that's coming from. And then looking at, confronting mortality and psychosocial gaps that the participants were expressing, some, really, disheartening and sad things that were expressed in the interviews around, the little bit of psychosocial support we got at the time was too little too late, all in major shock. It's the post-treatment where the support seems to slide off. Friends and family were like, oh, well, you're all better now. And so that was something that continually came up again across different cancer stages. And then speaking to healthcare providers, the methodology was very similar to our patients. And again, we did try to recruit diverse clinical backgrounds. It was we spoke to 12 healthcare providers. So it was physicians in oncology, palliative, we had family medicine, psychiatry. We also had nurses and a social worker. And here is a quote from a physician that, again, this is exemplifying an enthusiastic advocate towards psychedelics, where they say they feel that we are terrible at treating existential suffering at the end of life. And I think psychedelics have a potential, and it's deeply, deeply sad that it's not more easily accessible. And so kind of going through major themes, beginning with substance-specific caution to enthusiastic advocacy, we created a continuum of 5 different attitudes, and each participant would kind of lie and identify with each of the different attitudes depending on the context and the agent they were talking about. And for one participant, they felt that there was quite an ethical tension for them in palliative care, where they can offer medical assistance in dying, but they can't prescribe psilocybin, and they felt that that was a conflict. In contrast, here's someone who's very cautious, and they say, you know, the psychedelics, it can be a poison and a psychosis. So very strong language on either end of the spectrum. And then going into institutional silence and fear of professional consequences, continually when I spoke to the healthcare providers, there was, you know, some level of them expressing, you know, nobody wants to be known as that prescriber who uses hallucinogens. There's no way I'm even going to ask a colleague about this. Like, I can't risk it. So kind of, you know, needing, of course, to deal with the system realities, and they felt very restricted on what they could and couldn't even talk about. And then also a theme was around logistical barriers. So identifying that, you know, we're already spread so thin, we have very limited capacity as it is, and knowing that the prep and integration can be so, this is from people that, you know, have offered, you know, psychedelics in clinical settings, that it is so crucial to offer that, and they had no idea how the system could properly support them to do that, and, you know, otherwise leaving people with a lot of unresolved insights, which is what one physician told me about. So there's a little bit of our story across 4 papers that was my thesis. And what some of the key takeaways that I can say now is that patients showed the greatest amount of openness, and that was really driven by either the urgency that they felt, depending on the cancer stage they were at, but also just generally unmet psychosocial needs and the desire for meaning making. For healthcare providers, there has been literature, particularly in the United States, New Zealand, Australia, speaking to psychiatrists, I think oncologists, and a few other specialties around their attitudes towards psychedelics, and you just see this vastness of varying attitudes. So that is also what we saw in our work. And for policymakers, they really reflected their gatekeeping role. So, you know, where's the evidence, and you know, and an emphasis on the regulation and the safety. And again, I always I like to indicate, and an important part of our work was around teasing out the substance specificity of like how different they are, and needing to tailor our education in accordance to them, rather than using these umbrella terms around their effectiveness when they are so vastly different, pharmacologically and otherwise. And so to give you, so some of our subsequent work with, particularly the national survey that we did, it was 95 items. We asked a lot of good information, and a question that I often get asked is, well, what about within groups? Like the within group analysis of, you know, for patients, how did, you know, wanting to understand more about their prior psychedelic use, their expectations for them, and more experiential factors. And we were able to ask in the survey about reporting on their anxiety, their depression. We also use the demoralization scale, and we want to, you know, run correlations between that and clinical variables, so the type of cancer and the stage, as well as we did ask them about which psychedelics have you tried. And so we gave them a, you know, very long list, and then within that list, then they could break down each unique experience with those different psychedelics if they've tried more than one. So getting more information there. And then similarly for healthcare providers, you know, each discipline, you know, they all have their own stereotype in medicine, and we wanted to really understand, you know, how do the disciplines differ in their attitudes and beliefs towards psychedelics, and also the years in practice. And then similarly we also asked about their personal and clinical experience with psychedelics and how that intersects. And hopefully, you know, identifying early adopter providers and developing that targeted education and knowledge translation strategies to support that clinical readiness that we need. And so here are just, briefly some preliminary patient insights. So for patients, the most common psychedelic they have tried is psilocybin, and then followed by MDMA and then ketamine. They reported 84% had a positive experience rating, whereas about 12.4% were neutral. So that would be interesting to understand who has a neutral psychedelic experience. And then for the mean demoralization score, for participants that reported to have stage 3 or stage 4 cancer, they gave a mean score of 16.1, and the cutoff for significant demoralization is 11. So again, there's some really interesting information here to understand, like how will that then correlate to, of course we'll hypothesize that will correlate to, greater openness and interest toward psychedelics. So to bring it full circle and to conclude my presentation, so when Dostoevsky wrote that each blade of grass, each little bug, each golden bee knows its way, and ceaselessly enacts the divine mystery, he was describing something beyond reason, an innate order, a balance between chaos and meaning. In many ways, this mirrors what our work across CAN-PACT, seeks to illuminate. Psychedelic-assisted therapies are not simply pharmacological tools. They sit at the intersection of biology, psychology, and spirituality, touching something elemental in the human experience of suffering and healing. Our findings across the studies that I walked you through today, from evidence synthesis and our systematic review to patient and professional voices, call for a similar kind of harmony. So rigorous safety, grounded research, a deep collaboration with patients and policymakers. So like Dostoevsky's vision to every small element contribute to a larger living order, thoughtful implementation of psychedelics requires that each part, science, ethics, training, access, moves in concert, ceaselessly enacting a shared responsibility for compassionate, evidence-based care. And I just want to acknowledge, I've highlighted, it takes a team, and I also had Dr. Mayo and Dr. Shore, who I actually met midway through my master's, but I told Dr. Shore and Linda, he's too cool and I need him on my committee. So thank you everyone for your time.
It's an amazing body of work, and I think we have time for a couple of questions. Oh, there's lots of, okay, let's go there.
So really quick, and you may not have the answer, but it's something I keep wondering. With respect to demographics across the groups that you're talking about, do you have any sense of how much age in particular is sort of a working variable around people's perception of risk across those categories of policymakers and providers?
Yeah, so when we ran our linear regression model for what predicted positive attitudes towards psychedelics, we did run age as a factor, and what we did see that age was being an older age was a positive. This is very soon. What you did see in previous literature was a positive predictor for being more in favor of legalization.
Older people.
Older people, yeah.
Younger people had more positive attitudes.
At least for that predictive model, that's what we saw. And so that's why we want to do that within group to understand how those demographic variables, tease that out a bit more and understand it further.
But we definitely have that data.
Yeah, I have a big question specifically about what happened around drug education in the 80s and whether we may actually see a dramatic difference in sort of the Gen X cohort due to the effects of sort of statements.
Yeah, and that was something I was quite interested in, and particularly in the interviews when I spoke to patients, and it was, I think we had about 60% female, and then the remaining were male. We were able to recruit diverse ages, but for the older populations, again, I was really expecting them to reflect that war on drugs era, but I did not see that at all. There was just a total openness, and they didn't. Some of them maybe mentioned it, and they just didn't even. I think
did you get older hippies? So there's this sort of three generations, like little hippies who had personal experience, the Gen Xers where we were all terrified of drugs, and then the millennials.
I had an older hippie and a guy that was very conservative, who won't drink, won't smoke. And in the context of what he's gone through in his cancer experience, he's anything. That was the sentiment from all of them.
So the interesting thing, I don't want to dominate the time, interesting thing is across most substances when you look at in Canada, we're strongly deferential to whether a clinician has prescribed something or not. And you see dramatic differences, like how do you feel about legalization, et cetera, within sort of a medical model or otherwise, and you see, unlike other countries, that we really strongly defer to medical authorities.
Yeah, and certainly a chief concern was expressed around the loss of control. I just don't want to lose control, and I want the right support. And in that context, they felt very in favor of it. But in terms of like misconceptions, I saw it most with MDMA actually. But like MDMA's from the 90s, that's a party drug. Everyone's lovey-dovey. I want none of that. I saw that, but not with other agents.
Yeah, thanks. I just wanted to comment. So thanks for the presentation, Haley. I think this really, highlights a lot of good information about people's perceptions and then questions moving forward too. I'm a psychiatrist and I've been working in mood disorders, ketamine for about 10 years, and I've also been working at the CPSA in terms of policy and accreditation for psychedelic psychotherapy. And I think one thing that's really comes out highlighted to me is how much this field has struggled in using the right language to describe what we're looking at. And I think that's one thing I'm really hopeful that this group, this is a big research grant, lots of good work moving forward, that there needs to be some clarity between outcomes, like are we looking at depression, anxiety versus end-of-life distress, because I think there is overlap, but I think they are very different. We do know that ketamine itself is a guideline-based treatment as a pharmacotherapy for depression. So there are people that don't need a psychotherapy if it's removed. And I think what's happening is the language is getting conflated, and there's these clinics popping up in Alberta that are offering ketamine-assisted psychotherapy for depression, for example, and people are going and paying $6,000 for this treatment, not knowing that they might not need a therapy in their case, right? So I think we're still learning about what is best for who and what indication, but I think the language in distinguishing whether it's pharmacotherapy only, whether it's an already established psychotherapy that we're combining with ketamine or a psychedelic, something like CBT that we could use with other medications as well, or whether it's a therapy that's very specific that needs the effect of the substance, right? So integrating the experience, the psychedelic or the dissociative experience, where that it's more of a psychedelic or ketamine-assisted therapy. So I just wanted to put that forth because I think that's something that it's been really hard to tease out because the field has been really confused by it so far. So I'm hopeful that we can maybe start using some language so that when the research comes out and we look at sort of education and knowledge translation, that the public is getting the right information about what they can access and what sort of has the best evidence.
Makes a lot of sense. But I think we'll be talking about that a lot in education subcommittee for sure. And so I think I'm going to wrap it up now. Thanks again, Haley, for an awesome talk.